Good morning, class. Just picking up where I left off yesterday so we can finish up chapter 57 on stroke. We are now on the nursing process, and the first step of the nursing process is assessment. And we want to look at the primary assessment, and it is focused on actually cardiac, respiratory, and neuro. And if the patient is stable, we're going to obtain a description of the current illness. And when we are doing that, we need to pay special attention to the symptom onset and duration, the nature, and the changes. Now, remember, when we're doing the assessment, you have the subjective and objective data that we need to obtain from a person uh, who has had a stroke. And I think I mentioned that earlier in one of the slides. It's documented in table 57-9, and that is on, let's see, I was going to give you the page in the book. Yes, your nursing assessment is on page 1357, and it has an outline of the subjective and objective data. Other information from a patient, caregiver, family member, and or significant others. All of that is vitally important, because depending on just how bad the stroke is, the person who is in crisis may not be able to give you any information. So, next slide. If the patient is stable, again, we're going to obtain the history of similar symptoms previously experienced, what current medications they're on, a history of risk factors and other illnesses such as hypertension, drug abuse, alcohol abuse, any of those things, lifestyle, any other comorbidities that we may think of, accident that could have led to the person having a stroke, if they have a family history of stroke, aneurysm, or cardiovascular disease. In the secondary assessment, that includes the comprehensive neurologic exam. And again, when we start off with the basics of a neuro exam, we are utilizing the Glasgow Coma Scale. And we look at the level of consciousness, and they do have what they call the NIH stroke scale. We want to look at cognition as well as motor abilities. Continuing with that comprehensive neurologic exam, we're going to do cranial nerve function. And I know, as I said, I tried to give you a variety of tools to use and study with, not just for your unit exam, but those things that could help you prep for NCLEX. And I gave you a paper with the cranial nerves on there, what the name of them are, what areas, and what areas they cover, and what kind of test you would do to assess whether or not there is a deficit in that particular cranial nerve. We want to look at sensation, proprioception, cerebellar function, and deep tendon reflexes. So clear documentation of initial and ongoing neurologic examinations is essential, and it is very important that we note changes in the patient's status. As far as our diagnoses, they would include, but are not limited to, decreased intracranial adaptive capacity, and that actually will be related to the decreased cerebral perfusion pressure of less than or equal to 50 to 60 millimeters of mercury, and sustained increase in intracranial pressure secondary to thrombus, embolus, or hemorrhage. Risk for aspiration related to decreased level of consciousness and decreased or absent gag and swallowing reflexes. We have impaired physical mobility related to neuromuscular and cognitive impairment and decreased muscle strength and control. And last but not least, we have impaired verbal communication related to aphasia. Other diagnoses are unilateral neglect, and that could be related to visual field cut and loss on one side of the body, that hemanopsia, and brain injury from cerebrovascular problems. The patient can experience impaired swallowing related to weakness or paralysis of affected muscles. Situational low self-esteem related to actual or perceived loss of function and altered body image. Now, if you want to investigate or inquire regarding some additional nursing diagnoses, you have the e-nursing care plan that goes along with your text, and this e-nursing care plan would be 57-1, and again, you can find it on the website for this particular chapter, because Elsevier does have websites or hyperlinks that you could go to give you additional information. We are now in the planning phase of the nursing process, and at this time, the goals of nursing care is established together with the patient, caregiver, and family. One of the goals is to maintain a stable or improved level of consciousness. Secondly, we can attain maximum physical functioning. Number 3 is attain maximum self-care abilities and skills. 4, maintain stable body functions like the bladder control is an example. 5, we want to maximize communication abilities. 6, maintain adequate nutrition. 7, avoid complications of stroke. And 8, maintain effective personal and family coping. That's just to list a few. You can have a range, a conglomerate of things when you are dealing with the emergencies of a patient having a stroke. Again, depending on where the stroke is, whether it's ischemic or hemorrhagic, just what vessels were involved, and again, how bad it is. So other goals, I read those, I'm sorry. I did. It took up a couple slides, and I just read through all of them off of my notes. I apologize. I didn't flip over to this, but this was the last things, the last 4 that I said. That's 5, 6, 7, and 8. To maximize the communication abilities, maintain adequate nutrition, avoid complications of the stroke, and maintain effective personal and family coping. Now, continuing with intervention strategies that we would institute. First is health promotion, and we have an important role in the promotion of a healthy lifestyle. Nursing measures to reduce risk for stroke are actually similar to those for coronary artery disease. Uncontrolled or undiagnosed hypertension is the primary cause of stroke. So we really need to be involved in blood pressure screening and ensuring that patients adhere to the use of their antihypertensive medications and home monitoring of the blood pressure. We really have a problem with our men taking those antihypertensive drugs because they do have a tendency to make men impotent. So whenever that thing not working, it's a problem. So we have to educate them and teach them other means or other sources in relationship to erectile dysfunction. Sometimes you even have to make a referral for the patient. So if a person is diabetic, it's very important that the diabetes is well controlled. If an individual has atrial fibrillation, an anticoagulant or aspirin may be used to prevent the risk of stroke. Because smoking is also a major risk factor for stroke, we need to be actively involved in helping patients to stop smoking. And I think I mentioned it before, chapter 10 in your text has those strategies for smoking cessation. Another important aspect of health promotion is teaching the patient and families about early symptoms associated with stroke or TIA. And if you look in your text, table 57-1 gives information on when to seek health care for these symptoms. And that is on page 46. 1346. I'm sorry, y'all. I'm a little loopy this morning. I've been up all night. I just got back to the school from Kendrick. I don't want to use that as an excuse, but please excuse me. So that's the quick, down, dirty, fast assessment on that page. And that fast assessment in table 57-1 is the easy way to remember the signs of stroke. And the F is facial drooping. And you want to see, does one side of the face droop or is it numb? You can ask the person to smile, and if the smile, look and see if it's uneven. Then the A is arm weakness. Is one arm weak or numb? Ask the person to raise both arms. Do you see one arm drift down or not? And then the S is for speech difficulties. Is the speech slurred? Is the person unable to speak or hard to understand? You can ask the person to repeat a simple sentence like the sky is blue. Is the sentence repeated back to you correctly? And the T is for time, and time is critical. If someone shows any of these signs, even if they go away, we are to teach them to call 911, and whomever that person is around, they need to get them to the hospital as soon as possible. And again, it is vitally important to note the time that those symptoms, the onset of those symptoms, because it plays a major role in the type of treatment that will be used for the person. Some additional things that we could do or follow up with that should be reported if that person has trouble seeing in one or both eyes, sudden trouble walking, dizziness, loss of balance or coordination, and if they suddenly have a severe headache with no known cause. And I know I've heard these people say that is the worst headache that they have ever had in their lives. It's not anything, they almost can't even find words to describe to you just how bad their head is hurting. So that's the pretty much what it talks about in that table of 57-1. So as you can see on this particular slide, again, it's talking about the reinforcement of reducing those modifiable risk factors, the things that they could do to help prevent stroke, and teaching them again how to reduce those modifiable risk factors, the ones that we know lead to strokes, particularly hypertension, obesity, and smoking, and those patients who are diabetics, whether or not their blood sugars are under control. With the respiratory system, advancing age and immobility increases the risk for atelectasis and pneumonia. So risk for aspiration pneumonia is high because of impaired consciousness or dysphagia with the G. Anytime you're talking about the G, you're talking about the gut and swallowing, that type of thing. When you see the S, you're talking about speech. So dysphagia with the G go with the gut, and dysphasia with the S go with speech. That's how I always remembered it. All patients should be effectively screened for their ability to swallow. They are to be kept NPO until the dysphagia has been ruled out. Nursing interventions to support adequate respiratory function are individualized to meet the needs of the patient, and that may include frequent assessment of airway patency and function, looking at oxygenation. You may have to suction a patient, looking at the patient's actual mobility, positioning of the patient to prevent aspiration, and encouraging the patient to deep breathe. Oral care should be administered at least every 2 hours for patients who are on mechanical ventilation, because that reduces the occurrence of VAP, that ventilated assisted pneumonia. And they have mouth care protocols for these patients who are on a ventilator, and you're supposed to keep the head of the bed elevated, and that mouth care, and usually respiratory is involved. And the first time I encountered it, it was a box. It had times on it at 4 hours, 8 hours, 12 hours, what we supposed to do. So much is done by nursing. It's the alternate hours. I know at Kindred, I want to say I think respiratory has the odd hours and nursing has the even hours, but it is a shared responsibility between respiratory and nursing. And we also want interventions that related to maintenance of airway function, and you can find that in it's actually nursing care plan number 58-1, and normally it says if it's a e-care plan, but it doesn't. But I kind of got a feeling that it is. However, in the book we do have a few typos, so I'm thinking that it's possible that that is a e-care plan. Neurologically, we want to monitor the patient closely to detect any changes that suggest one, extension of the stroke, that suggests they may have an increase in intracranial pressure, that they possibly may be having a vasospasm, or that they are recovering from the actual stroke symptoms. The primary clinical assessment tool we use to evaluate and document our neurological status in acute stroke patients is that NIH stroke scale, and it's abbreviated NIHSS, NIH stroke scale. It can serve as a measure of stroke severity and is a predictor of both short and long-term outcomes of stroke patients. It serves as a data collection tool for beginning patient care and provides a common language for exchanging information among healthcare providers. Additional neurologic assessment includes mental status, pupillary response, and extremity movement and strength. And you can cover all of those in the Glasgow Coma Scale. Also, we want to closely monitor vital signs. A decreasing level of consciousness may indicate an increasing in intracranial pressure. So we want to monitor ICP and cerebral perfusion pressure. And remember, ICP minus MAP equal CPP. So remember how to calculate that cerebral perfusion pressure. And I have to double check and make sure that I didn't say it backwards, because it's either ICP minus MAP or MAP minus ICP equals CPP. I'm a little loopy right now, so don't hold me to it, but remember how to calculate your cerebral perfusion pressure. We want to record our nursing assessment in our flow sheets, and in that recording, it should reflect a story of the patient. It should show communication of the patient's neurologic status. That way, if we got good documentation, you might not be at work, but when the stroke team come and pick up the documentation, you have impeccable charting where they're not questioning things and can clearly see that you have the patient progression communicated well. Now, with that cardiovascular system, our goals are aimed at maintaining homeostasis. Many patients with stroke have decreased cardiac reserves from secondary diagnosis of cardiac disease, and cardiac efficiency may be compromised. And that's what we see in addition to the decreased cardiac reserves. The patient can have some further compromise by any fluid retention, overhydration, dehydration, and or variations in the blood pressure. CVP, PAP, or hemodynamic monitoring may be used as indicators of fluid balance and cardiac function in the critical care unit where these patients go in the acute phase of the disease process. Nursing interventions for the cardiovascular system. We're going to monitor vital signs frequently, monitor cardiac rhythm, calculate intake and output, looking at the imbalances. Did they have more in than out, and vice versa, and regulating any IV fluids based on urine output. Besides monitors or telemetry, besides bedside monitors or telemetry may be utilized to record the cardiac rhythms. Hypertension is sometimes seen following a stroke as the body attempts to increase cerebral blood flow. It is also important to monitor for orthostatic hypotension before actually ambulating the patient for the first time, and neurologic changes can occur with a sudden decrease in blood pressure. We want to teach the patient active range of motion exercises, especially if the patient has voluntary movement in the affected extremity. For the patient with hemiplegia, passive range of motion exercises should be done several times a day. We also want to prevent VTE by positioning, and we do that to minimize the effects of dependent edema and using sequential compression devices for the patients who are bedridden, and they may be on those sequential holds. They may have some TED holds on, and they may be on sub-Q Lovenox. Okay, I'm sorry. I just got a little lost there. I'm a little tired, and I kind of spazzed out there for a minute. I do apologize. I was reading to myself instead of reading out loud because I kind of lost my place. But again, that VTE prophylaxis, which I had already said, we might have to give some Lovenox, and you know the unfractionated heparin is the heparin drip, and Lovenox is the low molecular weight heparin. And then nursing assessment for that VTE includes measuring the calf and thigh daily, observing for swelling of lower extremities, noting unusual warmth of the leg, and asking the patient about pain in the calf, and we know that that is a positive homing sign. Musculoskeletal system, and we are almost done. It's still quite a few, but excuse me, we are almost there. The goal is to maintain optimal function. So again, that passive range of motion exercise, it should be begun on the first day of hospitalization. If the stroke is due to a subarachnoid hemorrhage, the movement is limited to the extremities. We want to position each joint higher than the joint proximal to it to prevent dependent edema. And specific deformities on the weak or paralyzed side that may be present in patients with stroke include internal rotation of the shoulder, flexion, contractures of the hand, wrist, and elbow, external rotation of the hip, and plantar flexion of the foot. So we have to pay close attention to that paralyzed or weak side, because we may have to do some additional range of motion exercise on those particular sides. We want to optimize musculoskeletal function. We want to put a trochanterol at the hip to prevent external rotation, make hand cones to prevent hand contractions, and you can get some of those little soft spongy things from PTOT, but I always worked in indigent places, so I would take a face towel and roll it up and then put tape around it so it'll stay, and put that in the hands so that they don't develop contractures. Arm support with sling and lap boards to prevent shoulder displacement. Now, I know that I use those face towels, but you'll find a section in your book that says, do not use rolled washcloths in the place of hand combs, but I just know that every place don't have a hand comb, so I would rather use a rolled up towel than nothing at all, and a patient end up developing contractures. So we want to use a footboard for these patients, especially the ones that have spasticity. And the use of a footboard in these particular patients, that is has been controversial, because you don't know if that spasticity is so bad that it can actually lead to the patient hurting themselves. So that's kind of controversial. Rather than preventing plantar flexion, which is foot drop, the sensory stimulation of a footboard against the bottom of the foot actually, according to Lewis, increases plantar flexion. Now that's new to me. I have to visualize or get it in my head. I'm like, how would using a footboard increase foot drop? Because I've used the footboard to keep the feet straight, and I've also rolled up a bath towel to put on the outside to keep those feet in alignment. But according to them, the sensory stimulation of a footboard against the bottom of the foot increases plantar flexion. Experts seem to disagree on whether hand splints facilitate or diminish spasticity, and the decision regarding the use of footboards or hand splints is made on an individual patient basis. In regard to the skin is susceptible to breakdown related to loss of sensation, decreased circulation, and immobility. Now, together or compounded by the patient's age, poor nutrition, dehydration, edema, and incontinence, all these are contributory factors of the patient developing skin breakdown. So it is vitally important that we keep the skin dry, that we turn the patient at least every 2 hours, that we kind of massage those bony prominences and keep them off. We do shifting of the weight, especially if these people are out of bed and in chairs. We really need to do inspections of that skin. And you know, if they bedridden and we have them to pull and turn, they got the potential for shearing force. So we have to make sure that we protect and inspect that patient's skin. So again, for the skin breakdown prevention, I think I kind of just said some of those things. We want to relieve pressure by changing position. You may have to have a special mattress. I forgot about that. A lot of them have what they call a low air loss mattress. Wheelchair cushions when they are up in the chair. We want to position the patient on the weak or paralyzed side for only 30 minutes. Again, we want to provide good skin hygiene. We want to put some emollients on where the skin is dry, and we want to initiate early ambulation with these patients. Now, if you see an area of redness developing and it does not return to its normal color within 15 minutes of pressure relief, then the epidermis and the dermis layers are damaged. So do not massage the damaged area, because this may cause some additional damage. Now, in regard to the GI system, If the patient does not have a daily or every other day bowel movement, we want to check the patient for impaction. The patient who has liquid stools could be also checked, because patients will ooze around the impaction. So depending on the patient's fluid balance status and swallowing ability, fluid intake should be at least 1,800 to 2,000 mils per day. And the fiber that they ingest should be up to 25 grams per day. So a diet high in fiber, bulk, and roughage, and IV fluids, those all help eliminate the problem of constipation. Bowel retraining may need to occur, and this training will continue into the rehabilitation phase. A bowel management program consists of placing the patient on the bedpan or bedside commode, or taking the patient to the bathroom at a regular time every day. And you do that in order to establish bowel regularity. A good time for bowel program is 30 minutes after breakfast, because eating actually stimulates the gastrocolic reflex and peristalsis, but they may need to be adjusted as individual bowel habits do vary. In regard to the urinary system, if an indwelling catheter must be used initially, it should be removed as soon as the patient is medically and neurologically stable. A bladder retraining program consists of providing adequate fluid take, with most of it being given between 7 a.m. and 7 p.m., scheduled toileting every 2 hours using a bedpan, bedside commode, or actually taking the patient to the bathroom if that's possible. Noting signs of restlessness, which may indicate the need for urination, and assessment for bladder distension and palpation. Assessment of post-void residual volume is often done using bladder ultrasound. The ultrasound measures how much urine is in the bladder following voiding. So if urine remains in the bladder, incomplete emptying is a problem and may cause urinary tract infections. And sometimes, I know we mentioned earlier about using a bladder scan, and sometimes we may have to straight cap the patient depending on how much urine is being retained. Okay, next is our nutrition. And with nutrition, patients should have their nutritional needs addressed in the first 72 hours of admission to the hospital, as nutrition is important for recovery and healing. And that nutrition should have some proteins in it, because protein is awesome for wound healing. And we had talked about patients should not be NPO for more than 3 days without instituting some type of nutrition. So, the first feeding that the patient is going to receive, it should be approached carefully, but prior to doing that, they need to have a modified barium swallow. That's how you test the swallowing. You need to test chewing, gag reflex, and whether or not they are pocketing substances in their jaw in the back before we actually begin oral feeding, because initially they may have to have tube feeding. Feedings must be followed by scrupulous oral hygiene. and there are some safety alerts related to oral feeding after a stroke. So I would suggest that you look at those in your book. They pretty lengthy, and I'm really trying to get done with this, but let me see if I can tell you where they are so you can look at them. Okay, let me see. Oral feeding after a stroke. Let's see. I don't, well, so far I haven't. I'm not gonna say they're not in here. I actually don't see it on here. Well, I guess I'll have to read a few of them to you. The gag reflex may be impaired due to dysphagia and needs to be assessed. Therefore, the first oral feeding should be carefully planned. Before initiating a feeding, assess the gag reflex by gently stimulating the back of the throat with the tongue blade. If a gag is present, the patient will gag spontaneously. If it's absent, you want to defer the feeding. And do exercises to stimulate swallowing. Those need to be started as well. It says also that the speech therapist or occupational therapist is usually responsible for designing this program for the patient, but there is no problem if you as the nurse is involved in helping to develop the program. They do allow that in some clinical settings, and everything we talking about interprofessional care and a team approach, so there is no reason why you could not be involved with coming up with a plan how to feed your patient. Make sure the patient's in high follow position. We prefer that they would actually be in a chair with the head flexed forward for the feeding and for 30 minutes after feeding is done. The patient should remain in high follow position, preferably in a chair with the head flexed, and you want them up an additional 30 minutes after they finish. That's important for you to know. It really is. Various dietary items may be recommended by the speech therapy. Food should be easy to swallow and provide enough texture, temperature, and flavor. Crushed ice can be used as a stimulant. Avoid milk products because they tend to increase thickening or viscosity of mucus and increase salivation. You put the food in on the unaffected side of the mouth. The inability to feed oneself can be frustrating. And the effectiveness of the dietary program is evaluated in terms of maintenance of weight, adequate hydration, and patient satisfaction. And these interventions should be introduced during or in the acute care setting. Communication. An alert patient is usually anxious because of lack of understanding about what is happening because of difficulty with communicating or inability to communicate. So the stroke patient who has aphasia may really be overwhelmed by verbal stimuli. There are some guidelines for communicating with a patient who has had aphasia. That's in table 57-10. I did see that in there. And that is on page 1363 in your text. Nursing interventions that support communication include frequent, meaningful communication, allowing time for the patient to comprehend and answer, using simple short sentences, using visual cues, structuring the conversation so that it permits simple answers by the patient, and praising the patient honestly for improvements with the speech. A picture board is useful for communicating when we talk about the stroke patient. And you got the one with the pictures on one side, and on the other side they have letters that they may be able to point to and spell words for you. So yes, I love those little laminated boards, and they are nice size, nice size letters. They not difficult to read or difficult to see. So I thought I was gonna get through this without creating another video, but I'm 45 minutes into this one, so almost 46 minutes. So I am gonna stop here, and I know this last one will have us wrapped up, because like I said, it's over 100 slides. It goes up to 115, and we are currently at slide 88. So I'm going to close this presentation, and I'm going to start our very last one. And I really, really thank you guys. I'm sorry I sound so country, but I don't know no other way to be me. I wish I could come up with a special voice that I use when I'm recording. But I'm going to end this one, and we're going to start the very last one. Thanks a lot.